Hello everyone, hopefully you can hear me and see my slides. Yep, is that okay?
Perfect.
Yeah, great. Okay, so I'm just gonna give you a little insight into my journey, sorry. So I've put the dates up here, no shame, in my been in radiotherapy for a long time, and I trained in Belfast in Northern Ireland, and then I went straight off to Sydney, Australia, and actually that was one of the places where I learned a lot about planning. I don't know how to move that window away.
It's gone on mine now.
Yeah, okay. Where I learned a lot about planning, and but I think it was I'll go on to say that actually from my experience it was really useful to have quite a long clinical career before I went into academia, but I know everyone's different. I came back to London in 1990, and then came to the Marsden in 1992, where I spent a couple of years on the Linacs before I moved into the simulator and pre-treatment. And again, that's where I spent a long time. I think in the simulator, for those of you remember, you see how patients move, you see how organs move, you see how, of course we had to use contrast in those days because it was not soft tissue, but I really learned a lot about patient motion and reproducibility and patient setup. And then I came to Sutton in the year 2000 to start a research post, so that's over 20 years ago, and I'm still here. But that has changed as well. So my academic career, just looking at that, when I qualified, I did a diploma. But then when I came back to London, I noticed that everyone was now doing BSc degrees. So I converted it in a year's course. And then I think my sort of twitchiness must last about 10 years, because then I decided to do an MSc. And then I did a PhD, and now I've got an associate honorary faculty position at the ICR. But just to go through that looks all very, I think, you know, all people might look at that and think, oh gosh, that's very successful, easy, but I'll just go through the steps of that. But before I do that, I think we have to think about radiographer research and what research we can do. And I do think that it's best for us to look at the research where we can answer questions better than everyone else. And when I talked to some of the research active radiographers at the Marsden, we came up with that we're at the translational radiotherapy. It's technology and patient care. So we're at that patient technology interface. And I think, for me, that's where I think we can answer questions better than any other profession in that area. And that's where we're uniquely placed and should be looking at ways and openings to do research there, of course supported by the other disciplines, but again, if we want to sort of drive and lead research, I think that's the area and the field we should be looking at. So just coming back to my research career, I started in the year 2000. It was a cancer research campaign and Imperial Cancer Research Fund before they became Cancer Research UK. So it was a 5-year programme grant, and my main role was to implement intensity modulated radiotherapy. So that was radiographer training and patient setup and reproducibility, which, as I said, I'd had quite a lot of experience with in the simulator. And I think it was very much, the idea of the job was very much that I would work with research fellows and implement new technologies, and that's where I started to learn how to do research. So one of the first research fellows was Mark Bolle, and we looked at digitally reconstructed radiographs. It seems crazy that we did 6mm digitally reconstructed radiographs for the pelvis, but we looked at that and 3mm DRRs, and I remember thinking DRRs were very exciting. But that was something that we worked together, and we published a paper, and by doing that and working with him, I learned a lot about the research process, going through ethics, getting ethical approval, filling in clinical research forms, and the discipline of research. Then also, because we were implementing an IMRT, I was able to then do some research with radiographers looking at the implementation at the coalface and what our experiences were, because at that time we were one of the few radiotherapy centres in the UK that were delivering IMRT. And then there were more physics papers as well. So I was working with physicists, again, looking at the different techniques of IMRT. So just to give you, it's insight, you were working alongside people, you were trying to do some research that we owned, and then also very much in the multidisciplinary team. And then we had the first UKRO meeting in about 2002, and the lineup to do the opening talks was David Durnley, Ben Minehere, and Charlotte Beardmore, who's now a professional development officer at the College of Radiographers. David Durnley was running the marathon the day before, so he handed it over to Chris Nutting, and Charlotte was pregnant and she handed it over to me. And by me doing that talk, I met Ben Minehere, who was very encouraging and said, "Why don't you come to Estro?" And again, you have to think this is 20 years ago, and not many radiographers went to conferences like that. And without his encouragement and sort of thought of why don't you put an abstract into Estro, I maybe possibly wouldn't have done it for a much longer time. So I think it's really important to, I think as we get older, then look around at younger people that we can encourage as well and keep moving things forward. So the work went on, there were lots of research fellows coming through, so I was doing a mixture of work like working with the beam cath for reproducibility in prostate cancer, as well as implementing IMRT and other technologies. So my sort of research portfolio was building up. And then there was another CRUK programme grant, and by that time I'd seen an awful lot of research fellows go through, and I thought, well, why don't I do a PhD or something and try and formalise this? So I applied for funding and it was unsuccessful. And then Alan Horrocks, who was head of the research at that time, said, "We think you should do it anyway." I remember it was a one-line email, "Sorry about that, we think you should do it anyway." And again, when someone says something like that, you don't really say, "Oh, well, change my mind now." I thought, well, why not? So off I went, registered at the ICR, and did a thesis and assessment of immobilization and imaging technologies to improve radiotherapy. So again, it was taking a lot of the sort of the background, the ground foundation of my work and moving that forward. Just to give you an example, part of that work was Chris Parker was taking biopsies from patients to try and identify patients who would develop aggressive prostate cancer and who wouldn't, and inserting gold seeds. So he was much more focused on the non-technical aspects of this. So I then was able to look at the gold markers in prostate radiotherapy and actually sort of set up a simulated study that if we used no IGRT, what your margins would be, if you use bony anatomy, what your margins would be, and gold markers, and then if you did online correction, what your margins would be. And this work was then published in the Red Journal, and actually it became the sort of foundation for the CHIP trial margins. So I think it is important that we do work that we can actually translate into clinical practice. Of course, patient outcome is the holy grail, but if we can do research work that helps us implement studies that may improve patient outcome, then I think that's where we can contribute. Some other work around that time was the active breathing coordinator that I worked with Nikki Panakis. I didn't have a photograph of her, Judy Christian and Mike Brada. And again, I was looking at the patient acceptability, the motion, the reproducibility, how accurate it was. And we published quite a lot of work from that. And then it was interesting you mentioning the research meetings earlier, because one interesting study that, well, I found interesting was looking at diet and in the rectum. So I'm trying to see if I can get rid of that. There we go. So we try, this is Linda Wedlick, who's a dietitian. So again, look outside your professional boundaries and look at, there's lots of work about prehab and rehab, and physios doing a lot of studies of work like that we as radiographers could easily pair up with. But Linda and I looked at trying to regularise patients' rectal bowel motions by putting them on a high fibre diet. So it was a very detailed study, lots of food diaries that Linda developed, a Bristol stool chart that was always interesting. And we actually found it wasn't actually, sorry, these are the stool charts, and the patients filled in diaries, which were great. And actually the patients were really compliant at filling these in. And I think we've got a big resource in our patients as well in looking at patient outcomes and patient reported outcomes. So they filled in all of these information, and we actually find that the diet actually didn't make much difference to the rectal volume or the cross-sectional area or the rectal diameter. We had 22 patients in each group, and there was no significant difference. However, we did find gas correlates with rectal distension, which is much harder to manage, and I still don't think this question's answered. So any budding researchers, I still think it's out there to be answered properly. So looking at where your inspirations to come, I like this quote from Newton, and I think at that time it was interesting that all the people who were advising me were all, well, can you spot what's similar? They were all men, and there were very few radiographers. So this was 20 years ago. Some radiographers had gone into research posts, but historically hadn't stayed, a long time. They just stayed 1 or 2 years. So these were all doctors: Alan Horrocks, Mike Brada, David Dernley, and John Yarnold, and physicists Steve Webb, Phil Evans, and Mike Partridge. They were very much my mentors and people I learned from when I was working at that time. Of course, now the faces have changed, and thankfully there's some women there as well, which is good. And of course, there's radiographers, many more radiographers around now to help mentor and support and advise, which is great. And I think I put this slide in just to say this is one of the most satisfying pieces of work that I was involved in. It was a very good multidisciplinary team. Anna Kirby leading the heart spare breathing study, but because it was such a technical study, physicists and radiographers were very hands-on, and we had lots of output from this work, and it was successful, and we implemented it and helped implement it around the country. So that was certainly something I was very proud to be part of. So back to my academic position, I then applied for associate honorary faculty at the ICR, who hadn't had any radiographers do that. So I was unsuccessful. So I licked my wounds for about a year and applied again, and I wasn't unsuccessful this time. And then I did wonder what to do next. And at this stage, someone advised me. I was involved in the mentorship scheme at the College of Radiographers, and I suddenly thought, hold on, I need a mentor. So Rachel Harris at the college recommended Anne Moore, Professor Anne Moore, who was a physio professor, and I met with her. And I think a mentor is a really good idea, and it's good to have someone outside your hospital or outside your profession. But my main aim to meet with her is, what do I do next? Where am I going for this? Will I just coast it for the next 10 years, or what else could I do? And we only had one face-to-face meeting, and she said, I think you should go for an NIHR fellowship, and this is the clinical academic program. So I did, and I was successful. So I got a senior clinical lectureship, so clinical academic post, and my research is making real-time adaptive radiotherapy possible, and my clinical side is I'm working on adaptive radiotherapy, mainly on the MR-Linac. So I think the most important thing is to don't stop questioning, just think about what questions there are to answer, and also question yourself, where is your next stop in your career? Talk to people. Mentors are great. Use people seek advice from people within and outside your organisation. And I'd just like to acknowledge everyone mentioned in this presentation. Sophie Alexander, who I didn't mention, is actually taken over the research position, the CRUK research position, and this is the radiographers on the MR-Linac. Thank you very much for your attention.
That was terrific. Thank you, Helen. So we'll save the questions to the end of the session, but please put them in the chat. Up next is going to be Dr. Mike Bellick from University of Toronto and Princess Margaret Hospital, who was just a baby radiographer when I was working with him in Toronto, but he's done quite a bit in his tenure as a research radiographer over the last 10 or 12 years.
Can you hear me and see my screen okay?
Yeah, looks great, Mike.
Great. So thanks for the invitation to speak. What I've seen so far from Helen and Janelle is really exciting for you guys over there. I'm kind of jealous. I wish we had our own RadNet program in Canada. But nevertheless, I'm going to describe my own PhD experience and post-PhD experience. And I just want to point out that I know you asked me to speak about my journey as an established radiographer, but I still feel very much 4 years into my current position that it's still an ongoing journey, and I still don't necessarily feel super established yet. So I'm still working on it. I have nothing to disclose for this talk. So I'm going to describe my progression really from a neophyte researcher, so somebody who had no experience, to an independent researcher and a principal investigator. I'm just going to highlight really briefly some selected research projects over the years to kind of show the variety of things that I've been working on, and hopefully share what has worked for me and what hasn't worked for me. So kind of like Cynthia said, my path in research started very early, actually, while I was training to become a therapist. And I want to mention that experience because I feel it really set in motion what came after for me. So our undergrad BSc program here has an optional stream allowing student therapists to complete clinical research projects under a clinical supervisor. Now, my motivation for this at the time was really to just dip my toes into research to see if it was something that I'd even wanted to pursue in the future. And admittedly, at the time, I did it as a way to stand out in the job market, as only a few other students were doing research at the time. So I worked under the supervision of a radiation oncologist, Dr. Laura Dawson, who was really an exceptional research teacher, extremely enthusiastic and very motivating for me as a student. And she really showed me the possibilities of doing high quality research and how that can impact patient care. This was the project I was working on as an undergrad, and I actually had to complete later when working as a clinical therapist, but we did a prospective study modifying mobilization masks for head and neck patients, demonstrating that the accuracy was not necessarily compromised when we removed a lot of the material over the low neck, but actually skin toxicity was a lot lower because we removed that buildup material. So really, it was just a very practical project for RTT practice, and personally, it was immensely very satisfying to see that the research we can impact patient care directly. And actually, we're still doing this here at Princess Margaret over 10 years later. So I practiced as a therapist at Princess Margaret in Toronto. And even before I started clinical practice, the environment I was in was very academically focused, where research, including research by radiotherapists, was valued. So just to explain that a little bit more, this is a snapshot of where my clinical department looks like right now. So we're a really large group. We have about 160 RTTs at any given time. Nearly a quarter of the staff have graduate degrees, actually. Unfortunately, only 2 of us have doctorate degrees, so I'm hoping that's going to increase in the future, but still a large portion have gone on to do research degrees. And 10% are cross-appointed with the University of Toronto, so they can engage better in teaching and research. And the figure on the right is from a colleague of mine, Tara Rosewell, showing that actually research RTDs can be very productive. So this is kind of the cumulative number of peer-reviewed articles from therapists, either as first author or senior author over the years. And you can see we're already at over 200 papers done with senior authorship or sorry, significant authorship by RTTs. So overall, a really academically focused clinical and productive clinical department. Our department also had a really a lot of success with research therapist positions over the years. So these are typically funded through large grants that give RTTs protected research time, sometimes really sustained protected time over many years. So I was hired by a physicist, Dr. Christy Brock, who was working in a really cutting edge field at the time, developing deformable image registration tools. So working with her and her team, this really required me to gain new knowledge outside of RTT practice. So I gained that on the job, and that was in new areas such as biomechanics and mathematics and so on. At the time, those tools she was developing were very early, preclinical, not necessarily practical for clinical use at the time. But as one of the only lab members with significant direct clinical experience and direct patient care experience, I really felt that my contribution as a therapist was important, especially as someone who would be one of the kind of future end users of these novel tools. So I was lucky in that I was already working in a fantastic research environment at the time as a research therapist with a great project, great diverse lab members. Some were clinical, some were not clinical, and a great supervisor. And for me, this was pretty easy, no-brainer to start doing master's work, because I already felt like I was doing master's quality research. I really wanted to just kind of formalize it and get the degree recognized for it. So I enrolled in a master's program initially, and my program permitted transfer to a PhD without necessarily completing the master's program. And I did that because I kind of had some early publications and some early success doing a PhD. And admittedly, I mostly decided to do a PhD at the time because the opportunity was there. I didn't necessarily think too far ahead in what I was going to do with the PhD. In hindsight, I don't know if that was necessarily the best thing. It seemed to work out overall, but I wouldn't necessarily recommend that. Advice at the time of people to talk to. So at the time, there were no PhD trained therapists in Canada to talk to really get advice from on what a PhD could do for your career. So I was left talking to people outside the profession. And just to kind of backtrack a bit, how you differentiate what you're getting in a master's versus a doctorate. So in a master's course, you're really just getting your formal research training, and a PhD takes it a little bit further as you're trained to become more of an independent researcher. So again, since I was already deeply engrossed in research work, my transition initially to full-time master's student was relatively easy for me. The challenge for me was funding again. So not that there wasn't scholarships available, but it was a hard sell personally to kind of step back away from full-time clinical practice work and that salary and those benefits to becoming a full-time student again. So fortunately, my clinical department was very accommodating. I was still able to work part-time as a therapist, so I could still keep up my clinical skills and also generate some income. And I really made a priority to find my own funding. So I applied for like literally every scholarship and grant I was eligible for to supplement my income. And I was fairly successful over the long run in doing that. As I mentioned, it was a full-time program for me. So other people, some colleagues were doing kind of online studies because that worked for them personally. I decided to go all in full-time. So really to do kind of a classic kind of grad school experience for me. And my program was at the Institute of Medical Science at U of T, and it was very much a research-focused program. So very few courses and emphasized thesis work. So that's really suited me very well. Again, I was lucky to have a really great supervisor who I already had established a good working relationship with, and I can't stress enough how important that is when you're in grad school, that you need to find the right relationship with the supervisor. So again, I had some, other students and other colleagues that were also doing grad students or master's degrees, and you can kind of see when the fit isn't right with the lab and the supervisor, you can kind of struggle a little bit. So I would advise future grad students to kind of really look at if it's the right fit or not. And also for me, working with Christy, it was really the right balance of teaching and offering support, but also somebody who really challenges you as well. And of course, working on projects that hold your interest for 5 years or so helps too. So this is one representative paper I did from some of my work as a research therapist and also my PhD. So we were interested in using these deformable image registration tools to estimate the actual doses we delivered from patients. So we actually modeled organ deformation that we see on cone beam imaging. So this is an example for liver SBRT. We can calculate dose on these images and then really compare what we deliver from what we initially planned. And this study I showed that actually in the majority of cases for liver at least, given how much motion and deformation happens, sometimes we are very off course from what we intended. So after grad school, I kind of suddenly found myself with no research job. And at the time there was, in Canada at least, there's virtually no options for PhD trained therapists. So I was a little bit stuck. So I was encouraged by my previous mentors and supervisors to do a postdoctoral research fellowship. And the rationale being that, I could kind of be more competitive in the field, in the researcher field, if I did more training. And I was kind of convinced that, physicians and physicists also have to do more training after their doctoral degrees. So kind of analogous to like a clinical residency or a fellowship in oncology or physics, a postdoc could really allow you to do more training as a researcher. So postdoc is kind of an odd transition time, I must say. If you're doing your own research, driving much of it on your own, but you're still considered a trainee. And you have this underlying feeling that you're kind of sort of on a probationary period as a researcher and a scientist. So it's kind of almost like a 1 to 2 year job interview. Officially, you're practicing independent research under the mentorship of somebody who's already established. So I was working under David Jaffrey, who is a senior physicist and scientist here at UHN, doing my postdoc. Now postdocs, again, there hadn't been any other PhD trained therapists in Canada who had done this before. And postdocs, at least in North America, are kind of the standard if you're looking for a tenure track faculty position, at least at research-oriented institutions. But it was very unusual for a therapist, for me, to be doing a postdoc at the time. So I did it at the Techna Institute and decided to focus a little bit more on what I had been doing previously, and focusing on research in clinical medical physics. So I wasn't become a physicist, but I had just been orientating my research towards medical physics in that site. And in hindsight, a postdoc was actually a great opportunity, and it allowed me to demonstrate and prove my abilities to potentially people who would be hiring me later. So you have financial autonomy as a postdoc without a PhD supervisor hovering over you. You can really kind of choose your research direction, and it allowed me to have an opportunity to lead some projects and even started to supervise, at least informally, other researchers and students. And of course, it gives you more time to establish your publication record and start applying for grants as well. And for me, the most important thing that I got to do during my postdoc was really build my network, both in academia and also in industry as well. That helped in later years doing research. And it allowed me to find champions later when in terms of people supporting RTTs as independent investigators. So this is just, again, to show kind of a different type of paper I did during my postdoc. So rather than just looking at dosimetry that I was doing in past research projects, this is an example of a study where we're actually linking planned dosimetry with outcomes. So we were trying to relate liver SBRT plans to patients who actually developed liver toxicity after treatment, and then translating that into new planning objectives that we could use in the future to help avoid toxicity in patients. It's just a little bit of a different flavor of research. And during the end of my postdoc, I really started becoming more vocal in what I wanted to do with the leadership here at UHN, and I had help from my mentors and supervisors echoing my message as well. And I started collecting other job descriptions that my organization had been putting out for kind of allied health scientists. So again, it didn't exist yet in radiation therapy, but my organization did have a few AHP/scientist roles coming out in other professions like physical therapy and so on. So I really started collecting all those and started developing and speaking my message of what I ideally wanted to do here. And actually I ended up drafting what my ideal job description looked like and started to really kind of pitch it at my organization that this is something that they might want to invest in, again, as a starting off point, because the position had never existed before. And eventually a new job opportunity was created in the radiation therapy department, and it was done under the direction of Ellen Moyo, who's the current director here. So this position was posted that I was successful in obtaining, which is a radiation therapist clinician scientist. I think this is analogous to what Janelle was showing before. And really the mandate, or my mandate, is to create and maintain a research program, and an independent research program in precision radiation therapy in alignment with our own strategic objectives. And the idea is it's supposed to be the majority of the time research protected time with a number of clinical duties. Now, obviously, you can expect that that's going to ebb and flow, and sometimes it's much more clinical than research, but the idea is really focused on academic practice. I have a cross appointment with U of T, so that again allows me to engage more in teaching and supervising students, and also an appointment at a research institute, which allows me to apply for federal research funds. So my experience so far has been very positive. Again, it allows me to lead and contribute in a really unique way to translating new technologies to the clinic. So some things I've been involved in over the years are kind of translating the research of the formal registration into kind of clinical practice and dose reconstruction. So again, estimating delivered doses, and comparing that to planned doses. These are tools that we're starting to use more and more in clinic now. We also have an MR clinic that I'm involved in, and setting up strategies for adaptive radiotherapy. I do supervise some research therapists as well. Again, those come and go when the funding comes and goes, and currently have a number of undergrad students that I do research with as well. Applying for grants is now a regular part of the job. I can say I've had a number of failures, but also some successes too. And I think that's pretty typical when we speak to any PhD, definitely outside of the radiographer profession, that will happen as well. As you know, getting grant funding is very competitive these days. I think my number one challenge of the past few years is really positioning and developing the messaging of what I can contribute as an RTT researcher. And I'd say that in the field. So, you know, in science in general and from the federal funding landscape, if you have a PhD, you're well equipped to do science. But in radiation oncology, I still feel like there's work to be done on the messaging, on how a therapist with a PhD can contribute to the science. So I've been doing over the years a lot of research that might be considered, physics research, and vice versa. A lot of other physicists and oncologists have been doing research that could be considered radiographer research, and there's a lot of overlap. But I think the number one opportunity for us as PhD trained therapists, and this is what Helen said as well, is we are positioned well to ask the questions that are most relevant to RTT practice. So this is kind of just highlighting some work that's been going on for a few years and is still being done, is something I'm involved in, is trying to develop what kind of the next generation RTT model of care looks like. So this is kind of a schematic on our practice, at least here in Canada mostly, is it's very linear. The patient interacts potentially with lots of different therapists over the course of the trajectory of their cancer care. And that's not necessarily good for patients. There's lots of handoffs. So there's issues around patient safety and patient experience as well. So we've been developing over a number of years, and we've tested this in pilots, is actually partnering patients with a single therapist that actually can deliver treatment, plan their treatment, image the patient, and provide supportive care and follow-up. So it's reducing the number of handoffs for patients. We think will really improve the patient experience, but we actually think it's going to be really important as we do more complicated strategies like adaptive radiotherapy or integrating other modalities such as immunotherapy into radiation. So again, we've done this on a couple hundred patients in pilots. We actually have a clinical trial that should have been initiated now, but unfortunately is on hold due to the pandemic. We're actually going to randomize patients to receive RTT in different models of care. So I'm excited for that in the coming year. What's worked right for me? Again, just hammering home that message. I think finding the right fit with the supervisor, the lab, and the mentors is really important. Getting comfortable with failure and rejection is going to be part of the job if you're going to be a scientist. Have a plan as much as you can. I necessarily didn't adhere to my own advice, but I think especially as you're into your PhD, start to network and see what post-PhD life is going to look like. Collaboration is really important, especially post-PhD when you're trying to build your own research program. So you won't have necessarily the support of a supervisor to guide you. You're really going to have to step out of your comfort zone and collaborate with people. And then continuous self-learning. So again, I'm constantly trying to learn a new research methods still that support new directions in research. So to summarize, PhD trained RTTs, I think it's becoming a more viable career path now. I think we are going to face similar but also unique challenges compared to other researchers, but we can make important advances to science and cancer care. So thanks, that's all I have. I'm happy to take questions or roll to the next speaker.
That was great, Mike. I think if we put the questions in the chat, we'll deal with them after Dr. Yat Sang, who's our next speaker, finishes his talk and tells us about his journey. So some of you know Yat, he's done a lot of research with RTTQA, quality, and some really interesting stuff in radiomics. So Yat, will you share your screen and tell us about your journey, please?
Yep. Thanks, Cynthia. Let me do this. Does it look okay for everyone for the screen? Yeah, that's great. And so thanks, Cynthia, and thanks for the organizers for inviting me to be here for the event. And so it's always quite tough to do presentations after Helen and Mike. So if Mike calling himself as an early researcher, then I want to call myself as a baby researcher. I think that would be more appropriate. So hopefully I will be able to share some perspective about my research journey so far. So the overview of the talk, just a bit about my career path, why did I decide to do my PhD, something about my PhD thesis, and also about what have I done after my finishing my PhD. So my career path that I don't mind share my years as well. So I graduate for my bachelor degree in radiotherapy in 2002. And then I moved to the UK, kind of tried to do some soul searching and consolidate my career. And then so I work in radiotherapy for pre-treatment, planning, dosimetry, and treatment delivery as well. And in 2006, I completed my MSc in healthcare informatics. And I decided to change my career to be involved with the radiotherapy trials quality assurance group in the UK. And in 2014, I decided to go back to clinical. So I applied for a consultant and practitioner job at Mount Vernon again. And so that will be my current job. So for my personal perspective about doing a PhD, so it kind of go back to when I employed as a trial care radiographer within the RTTQA group. So for the job that I was employed to do, that I kind of got the opportunity to design and implement QA programs for clinical trials that require the effective introductions of advanced radiotherapy in the UK. So as Helen mentioned, that in the UK for the last decades, there's a lot of changes and there's a lot of rapid progress in kind of the treatment planning and delivery within radiotherapy. So I think this job that coming with a very good opportunity for me to explore the aspect. And then, so with the job that, over the 8 years that I was in RTTQA, I was quite fortunate enough to be involved in a lot of different collaborative projects with a lot of kind of clinical experts in the UK. So when I gone back to my clinical jobs, and then I got asked the question, says, what do I do with this? So then I decided to do a retrospective PhD by published work at my local university, as London South Bank University. So what is PhD by published work? So it is a thesis that comprise including a sole or multi-author works that have been submitted or accepted for publications. So it offers alternative routes to the award of a doctorate. But all the other regards, they will meet the standard as a transitional PhD, as Helen and Mike kind of detailed. So for me to go back, that, you know, is kind of think of a research questions that I can put my publications under the same umbrella. So the research questions that I come up with for my PhD thesis is about, is there a role of trials QA that influencing the development of evidence-based practice in advanced radiotherapy? So they come with 3 different research aims. So we try to answer the research questions through 8 kind of publications that I was involved in, which I will go through that later. So first research aims is about, you know, the development of a national radiotherapy dosimetry audit on the implementation of advanced radiotherapy. So I use 3 of my publications that involve in that sense. So since 2010, I think there's a number of UK centers that adopted the rotational intensity moderated radiotherapy. So in general terms, that require RadNet for clinical use. So the RTTQA group that will be just kind of required to adapt the existing RMIT credentialing programs to cover this new technique. So we kind of performed the first national dosimetry audit of the RadNet. So it's a collaboration between the RTTQA group, the IPEM, and also the National Physical Laboratory in the UK. So the 3 publications that I mentioned that, you know, we developed a novel treatment planning test for credentialing a rotational RMIT or techniques in the UK. And we developed a methodology of how to do a dosimetry audit on this technique in the multi-center setting. And the last publication is about, you know, actually the result of the multi-center dosimetry audit of this new technique in the UK. So on my thesis that, you know, we try to kind of prove that we're able to generate new knowledge to illustrate how the first UK national dosimetry audit can develop and facilitate through evidence-based practice. So we move to the second aim, and then, you know, we look at about how can we utilize the trial radiotherapy planning dosimetry data to support the development of advanced radiotherapy. So we correlated the trial radiotherapy planning dosimetry data collected as a part of the QA program within a clinical trial outcome data. So the trial that I've been using in the publications is the FAST trial. It's a FAST radiotherapy for breast cancer trial, which is the kind of the phase 2 trial before the fast forward, which we just seen the publications in Lancet this year about the 5 actions in whole breast radiotherapy. So the first publications that we've used is about, you know, looking at the breast size, you know, is there a risk factor for late adverse effect of breast radiotherapy? You know, what is the correlation of the kind of the dose and planning data for that? And second, we look at the kind of the impact of those kind of the inhomogeneity, mostly is that requires hotspots on the plan, on the late normal tissue complications after the kind of the hypofractionated whole breast radiotherapy in 5 fraction settings. And the third one that we look at is about the quality assurance analysis of about how kind of the fast trial centers, how compliant they are to the kind of the trials protocol as the UK multi-center trials. So for these 3 publications that it provided new evidence that, you know, the use of advanced radiotherapy technique can be a major contributor factors to the successful implementation of hypofractionations in breast radiotherapy in the UK. So the last research aim of my thesis is about the analysis of the influence of the trials QA on the implementation of advanced radiotherapy. So I included 2 of the publications that I was involved in. So, as I said before, that, you know, in the UK, the RTTQA group has carried out quality assurance for several breast radiotherapy trials, either phase 2 or phase 3. So we did a descriptive survey research to illustrate the influence of trials QA on clinical implementations of advanced radiotherapy. So the first publications is on about looking at if taking part in clinical trials influence the implementations of new techniques in radiotherapy of breast cancer. And the second, we're looking at specific trials that I was involved in, looking at the clinical impact of import high trial on breast radiotherapy practice in the UK. So from these publications that, you know, suggest that trials QA can be seen as a catalyst for implementing new radiotherapy technique by providing support and guidance to centers. So it's just a quick overview on my thesis so far. And so then, people may ask that, if there are any big changes in life after the PhD, because I got my clinical job, so I would say that not really. But all Mike mentions quite important is about your clinical mentor and the kind of the researcher you're working with. So I'm very quite fortunate enough that I'm working with Professor Hoskin. So Prof always asks me that, what's next and what do we do next for after I finish my PhD. So I try to summarize some points that, I've been doing or trying to pursue after my PhD life. So I try to enhance my publication records and then try to look at the different results and outcome data with dosimetry data with the existing funded research. I try to sharpen my clinical and leadership skills, and then I try to add an extra layer from the academic setting as well. So luckily that I've been involved in a local university at South Bank, so I'm able to do some MSc student supervisions with the aim of looking at professional doctorate and PhD students supervision as well. And try to increase my independence as a researcher as well. And hopefully I will develop my own research project and then involved in writing research grant funding applications. So I think Mike and Helen kind of mentioned in the talks as well. And I think it's quite important that we're able to establish our research network and then get to do a lot of different collaborations with different kind of researchers that you met, that we're able to stimulate and actually will nourish the research project that you want to do as well. So, able to take part, or should I say, to learn from different researchers, and then we're able to take the strength, and then so hopefully we're able to develop the joint research in a more comprehensive way. So in conclusions, if you, after this event, you're going to ask yourself, is it worth to do a PhD? I would say, yes, go for it. You've got perfect opportunities here. You've got two kind of fully funded PhD opportunities and the CRUK RadNet AHP Academy at the University of Manchester. So for the past few years, they actually are quite lucky to get to meet a few researchers that, at the University of Manchester. They're brilliant scientists, they're brilliant researchers. So you've got an opportunity to meet with them and work with them. And I think you should just, take the chance and go for it.
That was great. Thank you. Yeah, and thanks for the plug. We have the next 10 or 15 minutes to answer questions. So if maybe our three speakers from this session and Prof. York, if she's still with us, can turn their mics and videos on. I don't see anything coming up in chat yet, but I might just kick it off. So the next session that we're going to do is having highlights from earlier career researchers, so people who still haven't quite gotten over the hump of successfully completing their PhD. Do you guys have any top tips for people sort of at the beginning of this journey? I mean, I think for me, it was certainly much different when I started this 16, 17 years ago than it is today, and the perspective changes. So any top tips for some of our speakers in the next session or people wanting to apply to these PhDs? Don't be shy.
I think I can say, because Cynthia, I think for my PhD, I was done as part-time. So I was keeping my kind of clinical jobs, which may be slightly different to the kind of the full-time PhD opportunities. But I think for the researchers who is doing the PhD part-time, I would say that, we will go into quite a tough period of time in the middle of writing your thesis. And I would say that, hang in there, don't give up. Eventually we see the light of the tunnel. And then I think it's worth it when you complete it.
Yeah, I was going to say the same thing. Whatever route you choose, don't give up. I think for me, I really enjoyed keeping close links with the clinic, and part of that reason is why I've gone for the grant, which is the clinical academic position, because I think that keeps you sharp. It keeps you knowing what's current. So even if you are going to do a PhD full time, keep your links with the clinic somehow.
I agree as well. I think it's really how we're going to be uniquely positioned. We're going to have to stay very relevant in the clinic as well, as we build research careers. Advice during PhD, this is not my quote, it's from somebody else, I don't know who, but it's write early and write often. Myself, I was a brutally slow writer for all my papers and my PhD, and I probably could have completed the whole thing a year faster if I had a reasonable writing pace. So get it done early, and I think if you get the papers out early, at least for me, it helps a lot when you're going to defend your PhD as well.
Great. Okay, so then, so Helen and Mike certainly touched on this, and yeah, you sort of inferred this. So there's a bit of discussion about positioning us as clinical radiographers and the message about what type of research we can and should be doing. I think there was definitely a link through all three of your talks, and even through some of my work, which is again a little bit different than what you guys have done. Do we think that this is coming together? Do you think that formulating a joint message will help us move the momentum on in this type of work?
We've got to see the value of the work we do, and yeah, just focus on the yeah, just stay true to the work we're doing and believe that there is value in it.
And I think with echo Helen's, I think, when you're doing PhD, that I think, you do kind of plan. Actually, you need to spend actually quite a massive amount of time on a specific subject that you're going to work on. So definitely that it was something that you find it relevant to your clinical work, and then you're interested and you're passionate about. Otherwise, it'd be quite difficult that, you got stuck with a subject that you hated for 5 years. Then, that would be very difficult to finish it off.
Great. So we have a message from Elizabeth. She says, for part-time clinical and research roles, do the speakers have any advice on protecting that research time?
I think it is hard. I think it's to try and build some sort of structure in. I do think you end up being part-time clinical, part-time research, and then part-time everything else. So it does seep into your whole life. But lots of people are like that. I try and make some distinctions, like wear a uniform when you're clinical, work from home when you're not, or go and hide where you have to do your work or your planning or whatever. But it is inevitable that the research role is more flexible in terms of time, and the clinical role is more demanding in terms of patients at that time. So that's just something you have to live with.
Does it help to get your clinical supervisors or management on board early on in the process, like during the application process, to help identify how this may or may not work?
Yeah, possibly, but I think at the end of the day, on the day-to-day basis, it's got to be you and your judgment. And I think if you've got, good colleagues, but if they really need you, then you step in, and then at other times you step away and try and take that time back.
Yeah, definitely. I think as Hannah said, I think a job plan will be very important. And I think based on my own experience, and I will raise my hand up. And sometimes I think I do it myself, because sometimes I use my clinical work as an excuse as well. So, I think if you've got a job plan, I try to stick to it. A lot of time that, and I would say that I'm too busy of clinical work. That's why I'm not going to do any research. And I think it's about your mindset that, if you've got a job plan and then stick to it, ensure that your research output is stick to the timeline that you set out to. So you're able to finish your kind of thesis in a timely manner. So I think that would be the advice that I would be able to give for the part-time researcher.
Great. And then we have a question from Professor Finn asking to the full-time research teams, do you have any advice on keeping the close relationships with the clinic and ensuring clinical relevance of the research? So I guess the flip side of what we've just been saying.
I find that difficult to answer because I've done it part-time clinical or a clinical academic position. But I guess it's being visible. It's maybe working sometimes in the clinic. I don't know, maybe Yat or Mike has better advice.
So I can say for myself, even when I was doing PhD studies and I was working part-time 1 day a week in the clinic, the other 4 days a week, actually, my research was still based in the clinic. I've always been doing research in the clinical setting. So I've had a lot of visibility with staff still, still going to clinical QA rounds, research rounds, integrating as much as possible with the multidisciplinary staff as much as you can, even though you're not directly treating patients. That has worked for me. And even now in my role, I don't do any, by virtue of the clinical work here, therapists are unionized. So I can't actually do any of that kind of clinical work. But my desk is still right in the middle of the clinic, where actually most of the other leadership team, physicians and physicists have actually moved off-site. I've actually remained in the clinic. And for me, that's been really important because I don't do that clinical work. That proximity has been really important for me.
Great, and thanks guys. And from Jenna, any advice on how to choose a research project or where to look for inspiration?
I would say there are two just out there that's been advertised. So I think, that would be a very two, I would say that very clinical and as a very clinically relevant projects that has been proposed for the 2 PhD opportunities at the kind of University of Manchester.
I think the truth is too, potential PhD students don't necessarily get to pick their topic, right? A lot of it's driven by funding. So, and unless I'm mistaken, that kind of the RadNet program and the funding mechanism is sort of, at least loosely guiding where those projects are going. So, and that's not necessarily a bad thing as well. As researchers, and I'm finding now in my position, your research has to align with where the funding is the truth.
And then from Professor Van Herk, he's asking that RadNet we're a large part about biology. What opportunities do you, as experienced RTT researchers, see within this grant? Or in other words, what ideas for new RTT projects should we write next? So yeah, you do a lot of radiomics. Is there anything there that we could, combine, do you think?
And I think to answer that, I think I tried to kind of follow what Mike suggested in his talk as well. I would say that it will be based on the individual's interests and abilities and also the strength as well. Because I think if we see it as, we're all healthcare scientists, I think, that we've got research questions that we want to answer and we try to establish a method to answer it. So I don't think that we will have the kind of a clear cut about, this project is purely for clinical oncologists, or this project pure for RTT, or this project pure for physicists. So, and I would say that, it will be, if that individuals that got specific interest in a certain topic, I think they should go for it. And then, and try to sharpen their skills. And then, and kind of, as Mike said, that, we just carry on developing ourselves and to ensure that we'll be a more rounded researchers in the field that we're interested in.
I think the key is going to be for kind of the up and coming and established RTT researchers is again to see the interface between the patient and these new modalities. What role can we specifically develop in therapy? So, if we're talking about comorbidities, how can therapists support that? Is it going to be therapists either assessing patient or establishing the patient relationship to get patient-reported outcomes? What really narrow tool do we have to develop to get high-quality data to study, immunotherapy, radiotherapy interactions? Or if it's not with the patient interface, what other, facets of therapy do we have to develop to study immunotherapy? So if we're studying imaging, I'm just trying to think of my own work. So, studying doses we're delivering to organ subunits, for example, how does that show up on imaging? And how do the biological changes show up to those subunits on imaging? So we're just gonna have to really to move the needle, so to speak, on the outcomes. I think we're gonna have to really double down on some of these narrow facets of therapy. So is it going to be the patient patient-reported outcomes, or is it going to be more of the imaging and technology stuff? So I think that's probably the opportunity for therapists to really develop, I think.
I think that's coming quite well to link into Marcel big data project. So, you know, all these things that Mike mentioned that, you know, can all link into Marcel's project in big data.
I was going to say, Marcel, you're just asking us for all ideas. I would think, you know,
Yeah,
maybe
sure.
sometimes we need to stand back and think about how we do things differently. And I think that's a lovely example of what Mike was talking about earlier. With hypofractionated radiotherapy, how can we can look at the whole pathway of the patient and how can we deliver that differently instead of just trying to log into what we've been doing for 30 fractions. I think it must be it got the opportunity to be very different.
Another idea, again, kind of plugging into that last project I was talking about, moving to this new model of care where we kind of have a single therapist overseeing all these facets of therapy. Part of the impetus for that was that we expect, you know, with new therapies coming online, like immunotherapy, treatment trajectory is going to become a lot more chaotic. It's not necessarily going to be linear, plan, scan, treat. It's going to be, you know, changing and adapting as the patient's responding treatment. So having a therapist oversee all that complexity and guide the patient through, I think is going to be really important. So that's kind of one angle we're trying to address now, kind of building the foundation for that.
That's great. If there's no more questions, I'd like to thank our speakers once again for giving us their time and sharing their experiences. And I would imagine if you wanted to reach out with further questions, they'd be receptive to hearing from you. So I think with that, we might move on to the next part of this event and hear from some slightly newer research rads, some who've been research active for a very long time, but all certainly who are sort of still in the process of applying for or completing their PhD. So we'll start with Mark Warren, who works at the University of Liverpool in the radiotherapy education program there and is working along the NIHR pre-doctoral and doctoral pathways.